All right, we're going to get the party started. So our first speaker today, Nannette Cox-Kennett, completed her Master's in Nursing in 2004 at the University of Alberta, and she's been a nurse practitioner for hematology and bone marrow transplant program at the Cross Cancer Institute here, providing outpatient care to persons, she's amazing, that are receiving your transplants, your bone marrow transplants, stem cell transplants, all kinds of fun things. And through the years, she's been recognized as a leader in oncology nursing, having received the Myeloma Canada Marion State Nursing Award for her leadership and excellence in patient care. The Leukemia Lymphoma Society Excellence in Patient Advisory Award, Cano Award for Excellence in Nursing Practice, Helene Hudson Memorial Lectureship Award, and a nomination for Cano Oncology Nurse of the Year. So Canadian Association of Nurses in Oncology? Awesome, okay, that's what Cano means. We always have alphabet soup. We were talking about that earlier. So Nan is very passionate about education, and she tries to make anything complicated understandable, and I think you're really going to enjoy her style of teaching. So welcome, Nan, and thank you for joining us. Anybody online, please put questions in the chat and we will respond to questions as we go. But remember, microphone.
So good morning, everybody. I am curious how many in the room I've met before. So few people who've sat through some teaching sessions, potentially at the Cross, and are familiar. So what I'm going to do today is basically talk about the basics of your blood work and what, as a clinician, I'm looking for, and sort of kind of taking this very potential complicated topic and giving you sort of the simplified version. So I want to be clear that this is not the fancy scientific version. This is how I basically, when I look at the labs, this is how I think about them. And I'm going to tell you what to ignore and what I think is kind of important when it comes to myeloma. I don't like to do this lecture as a PowerPoint slide presentation, which I'm sure many of the lectures you've seen yesterday and later today will be. And it's because this is something that's a little bit hard to do in an engaging way by PowerPoint. So what we do is we kind of go through and we doodle as we go with a sample of patients' blood work up here so that it can be a little bit more engaging. So what I'm going to start with here is your complete blood count. And so every visit that you have with your provider, this potentially is also on the menu as a test that's being looked at. And the complete blood count is completed by a machine. So there's not a person looking at this. The cells are going to be dropped through a little portal, and the computer analyzes them and says, oh yes, that's a this, and that's a this, and that's a that. And then because it's a computer, it can do some fancy tests like measuring how fat and wide they are. And those are the things that, the machine can do it, but is it relevant to us every day? Then you don't get the whole page. Bring their chairs closer. All right, that's louder. All right. So I can, the problem is that if I do that, it's big, potentially bigger, and now there's a shadow, and so I'm gonna just. Okay, I could move this closer. That's not a problem. It just feels kind of weird. It's like I feel like I should be breaking out into song or something. Anytime. And only at church. When I'm one of a crowd and nobody can tell. Okay, so we'll try to do this, and then is that a little bit bigger? Yes, no, maybe so? Okay, so then we'll just try to move it up as we go. But now I've got a shadow, see, in the middle. So that's the. Yes. And this is it, and they've got a pot light. Exactly.
Oh, that's better.
Is that better? Okay, all right, so we'll have to kind of wiggle this a little bit, but let's do it. Okay, so starting at the top of the page, just going to press my autofocus. Okay, so starting at the top of the page, we've got our white blood cell count. And so white blood cells are guys that fight infection, and that can be viruses or bacteria. So those are going to be important because sometimes when we're receiving treatment, our white blood cells might get caught in the crossfire. And so they might go a little bit low, especially if you're on drugs like cyclophosphamide, which may have been something that you received maybe in the beginning or maybe never at all, but that's an old-fashioned kind of chemotherapy. When we look at white blood cells, there are different kinds. And so there are guys like neutrophils, lymphocytes, monocytes, eosinophils, and basophils. And so these guys, they fight bacteria. And when we're looking at treatment, these need to be usually at least 1.0 in order to go ahead with our next cycle. And so if it's too low, we're at higher risk for infection. And so the physician may hold your treatment or potentially reduce the dose of your treatment so that things might be a little bit safer for the next cycle. Lymphocytes are guys that mostly fight viruses, and they typically are not necessarily impacted by treatment. And then these guys are a little bit less important. I really could care less if these, actually all these four, if they're low during treatment, I really am not going to care. And so I don't need to take those into consideration when it comes to treatment. I'm really only looking at the neutrophils. Eosinophils are elevated with bugs, drugs, and parasites. And so I've also recently seen that eosinophils go up for people who are taking cannabis. Basophils and monocytes are also part of our immune fighting system, and they have some very unique roles. Oops, my camera disappeared. There we go. So back up to the top, our next up is our red blood cells or erythrocytes, and these are kind of tied with hemoglobin. I want you just to ignore what the red blood cell count is because what we really care about is the hemoglobin. So red blood cells versus hemoglobin, the way I think about it, hemoglobin is the stuff that has the potential to carry around oxygen. So how many of these cells are actually carrying around oxygen? And so the hemoglobin can also become lowered when we're on some types of therapy, and we typically don't get excited unless that number is less than 70. At less than 70, we would want a blood transfusion, but as long as it's above 70, believe it or not, that's like working off, if you look at the normal 135 to 175, that's like working with half a tank of gas, and our body actually pretty much won't complain. It will complain when it gets below half a tank of gas. And how does it complain? We can get swelling in our feet, become short of breath and super tired, and we'll also look super pale and vampire-ish because we're not having enough of that nice pinky glow. So when I said that the computer can analyze some things, these are all the things that I'm talking about. These are basically how fat are the red blood cells, and I really could care less. So even though they're, are they fat and fabulous or are they super skinny? I'm only going to care about this particular number called mean cell volume. This number should be between 80 and 100, and it will give me a clue. If the hemoglobin is low, it will tell me if the cell is really small, it could be about iron deficiency. If the cell is really fat, it could be about vitamin B12 or folic acid deficiency. And so that's the only time I pay attention to that, but these other ones I never look at ever. And I work in the blood field, so I'm not looking at that. Moving on to the next stuff that's most important when it comes to myeloma. One of the first clues that a person might have a trouble with multiple myeloma is their total protein. So protein is a major component of our circulating blood, and the largest protein in our body is something called albumin. And so if somebody comes in and they have a high total protein number, I'm gonna be like, what is it that's high? And so and if the albumin is normal, I'll have a clue that there's some other protein that is contributing to this total protein, because my albumin is normal, which is my largest amount of protein, but my total protein is at 92 for this person, and it should be between 60 and 80. What is it that's making up that 10 extra grams of protein? I need to go and have a clue or have a look and to see what those are. So the first protein I might look at is your immune globulins. So immune globulins, these are proteins, and they are basically part of our antibody defense system. And so when I look at these, the way I think about it is IgG equals gone, and IgG equals morning. And then the way I'm thinking about that is the morning is my early response to infection. So if I was exposed to a virus, I would initially produce IgM, an antibody, to go fight off that virus. And then as I developed immunity, it would become IgG, which meaning it's gone. The virus has been fought, and now I have this immunity antibody or protein circulating to keep me immune. So I had chickenpox, I had some IgM morning chickenpox virus, and then as I cleared it, I now have some IgG circulating chickenpox antibody that is now going to keep me immune to chickenpox for the rest of my life. So what if this is super high? And so in order to understand this, I think it's a little bit easy to, to kind of put it into context. I don't know how many of you sort of understand sort of the basics of the cell of origin of when it comes to myeloma. And so this is the way I think about it, that, this is a white blood cell. His name is Bob. He is a B cell, and he has a little arm sticking out here that's constantly searching for viruses and bacteria. And he's part of the lymphocyte family. Remember I talked about how those are, there's the lymphocytes fight viruses. So Bob has his little arm out, and he's constantly searching for viruses and bacteria, and he comes across chickenpox. When he comes across chickenpox, he's like, oh, I found something. And he takes a little sip of it, and he goes running to a big boss called Tom the T cell. And Tom says, oh, did it again. It's just because it's not seeing that I'm doing anything. There we go. Tom says, did you kill it? And he says, well, no, I just was told to bring it to you. And he says, that's okay. And Tom sprinkles him with pixie dust, and he transforms him into a plasma cell. He now has little guns that are going to shoot off antibodies. And he's going to go pew, 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 killing the chickenpox everywhere he says it, pew, 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 pew. And then once he's done the fight, he's now going to become a memory cell so that he now can continue to shoot off chickenpox. I'm ready and armed and dangerous at any time. So this guy is where myeloma is overproliferating. So this is where your cancer is. There's too many Bobs, and all of them are producing these antibodies. So one of these may be elevated, and so you can see for this person, it happens to be IgA is elevated. And so this should be less than 4, but this person has an IgA of 34. So that's what's contributing to this higher total protein. All of these are proteins, all of these are antibodies, and all of them are then contributing to that super high protein number in the beginning, because albumin was normal. It wasn't albumin that was a problem, it was all of these antibody proteins. So an antibody looks like this. It's got these big long arms that are called heavy chains, and then it has 2 little tiny arms at the side that are light chains. And so if this was IgA, there can be these light chain parts, they express something called kappa and lambda. And when we have myeloma, we may see the whole protein overproduced, and sometimes we will see just a part of the protein being overproduced. And so some people may have what's called a free light chain myeloma, because all we can measure is the free light chains. So when we look at their total at IgA, et cetera, these numbers might be normal, but when we look at specifically a test for free light chains, we can actually find just these free light chains in circulation. So that free light chains, I don't think I have a specific, yes, I do. So those free light chains are a very fancy test. This is not going to be something that's in your family doctor's repertoire. They're not going to be clued in that if I came back with a high total protein and a normal free total immune globulin level test, that this should be the next thing I do. This would be only something that a specialist would have in their head. So Brian, you've got the, so the, sometimes it is very difficult to have your myeloma diagnosed if the only thing you are excreting is these free light chains, because it's going to be a test that only an expert is going to recommend. And so sometimes what's happening is that there's a high index of suspicion that this person has myeloma. There's a phone call that goes in to a hematology specialist, and they'll say, please order this fancy test. The gold standard would be a bone marrow biopsy to check the next part. And that's because where is Bob living? Bob lives and is born in our bone marrow, and he pops out, comes out into circulation, then he checks back into the bone marrow. It's like a constant circuit. He's out, does a tour, pops back in. And so by going into the bone marrow, we can see how many Bobs are hanging out there, and that tells us whether or not you have myeloma as well. So, to get that diagnosis, we're not going to do bone marrow biopsies on everybody off the stop right off the hop, because it's a very invasive test. I'm sure all of you have had it. And so we want to start off with the things we can do on peripheral blood. And so that would be this specialty free light chain test. And you can see this person has a high number of just these lambda light chains. So the next test that we're looking at then is this serum protein electropheresis. So again, this is all about those proteins. And this is what's giving us that M peak that we're looking for. So, this is a common slang or lingo for monoclonal peak. And so I want you to just focus on the graph part here. So when I talked about albumin being the largest protein in our body, there it is. And then there's all of these guys here. And this is going to be other proteins that have been graphed out. And these are going to include things like thyroid hormone and testosterone and estrogen and clotting factors, things that help us to form a clot. So all of these are these little peaks here. And but this person has a monoclonal peak of 30, and so it looks like this. So there's this big peak at the very end of the tail that shouldn't be there. This is a normal electropheresis, and it just is up and then wiggle, wiggle, wiggle. This person has this big spike at the end, and so this is all of that IgA that this person has in circulation that shouldn't be there. This should be down here. So our goal with treatment is to get rid of that. So hopefully when you're first diagnosed, we're getting all of our treatment, and that is disappearing and getting smaller and smaller and smaller over time. And that's how our physician is measuring our response to disease, watching that monoclonal protein or free light chains get smaller and smaller and smaller over time. And then once we've got it down into the controlled level, then we're watching that it stays there. And if it starts to creep up, we know that there's additional or change in treatment needed. The next test is something called serum beta-2 microglobulin. And this is basically something that's secreted by Bob, and we can measure that, and it's part of our staging criteria, and in terms of myeloma, how much of this is being secreted, and this is taken right off your Myeloma Canada website, and your international staging criteria. If there is, how much Bob is there circulating, how much albumin is there, remember, our body is going to, if there's too much protein, our body's going to say, I obviously don't need any albumin because I already have a lot of protein. And so it's actually going to reduce the amount that it's producing. So as the total protein goes up, the albumin's going to go down because it's kind of a compensatory mechanism. and it's wanting to keep everything sort of at a specific level. And so if the albumin's going down, that tells us that there's more disease and that it's been going on for longer. LD is a test that basically is for cell turnover. This tells me, are the cells replicating really fast? And we can see this a little bit elevated in myeloma, but I tend to see it more elevated in other solid tumors, not so much in multiple myeloma. Genetics. Has everybody in this room had their genetics done? No, maybe not. Okay. So when it comes to genetics, I'm going to pull this piece of paper over here. We're born with 23 matched pairs. So you get a 1 chromosome from your mom and a 1 chromosome from your dad, and a 2 from your mom and a 2 from your dad, and a 3 and a 3. And so at the end of the day, we've got 22 matched pairs, and then somebody's going to get an X and somebody's going to get a Y. So with cancer, we can see changes in these genetics. We can see a gain of something, so you have an extra of something, or we can see a deletion of something, and that deletion may be all or part of the chromosome. So I want you to imagine that the chromosome looks like this normally, and it's got 1 long arm and 1 short arm. Then this is my 22s, and then a little portion of this can sometimes flip and get moved onto there, and we call that a translocation. So either we've got an extra 22, we've got a missing part of 22 or something just gets cut off, or we've got things that have moved. So things can move within the same gene, or things could move from 3 to 22. And so a little tiny bit of number 3 gets moved onto 22, and it's over here, got cut off and moved over here. And so the translocation can happen within the gene or to a whole different gene. And so we can actually measure that. We can put little tiny probes into the cells that we've collected by a bone marrow biopsy and have them look and tell me how many chromosome 17s do I have. And so it should all light up with these matched 2 little 17s here and 2 little 17s here. And so I can see them all together. But what if I've got only 1 lighting up here and there's not a little pair beside it? That tells me that that particular cell is missing a chromosome 17. And so that's one of the kind of old-fashioned, we call that fish fluorescent in situ hybridization, or so FISH, and that's where we're inserting this probe and things light up and tells me if they're together. And so the FISH is a manual test. The probes get put into the blood, and then literally a person in a lab is looking at that under a microscope and looking for those glowing probes and how many are grouped together, and it's very labor intensive. And so when it comes up to there, the report will be how many things am I seeing that are paired or not paired. And so they can also now develop probes that are looking for these specific things that have been moved or translocated. We know that when chromosome 11 and 14 have moved places, we could actually create a probe that looks specifically for that change. And so again, it would light up differently with that probe. And so for this person, that probe was normal and not there. For this CK18, there was a single copy, meaning that something has been deleted because there's only 1 copy and there should be 2. And then this one, again, there is a deletion. And this here, for chromosome 17, there is a monosomy, meaning only 1 when there should be 2 of chromosome 17. Oh, thank you. We need to figure out a way to make that not happen on a regular basis. Or I just need to go over and poke something. So the genetics are a complicated test that take a lot of time. And so this is not like CSI when you watch the show and they swab the mouth and they come back and they go, we got the results and he's our killer. This is not happening overnight. This takes a long time, first for the cell to respond to the probe and then for a person to actually sit and read it. This is typically something that can take about a week for all of the specialized tests to kind of marinate. It's not something that happens in 5 seconds. And so these results will tell your provider sometimes a little bit about what's the best treatment for you, because this response, this particular genetic change responds better to that particular drug. And so that can help them to make some treatment decisions. So we've gotten a little bit better at doing this test, knowing that this was so complicated. Is there a way to kind of get this a little bit more automated and have it done by machines and not by people? And then that comes up now to this, what we call next generation sequencing. So what if I can put that blood into a fancy test tube that will break the products down and actually allow a computer to analyze all of the proteins that line up in one row for that chromosome and tell me, is there things that have moved around that shouldn't be moved around? And so the computer can actually be programmed to look for these particular gene locations and do they line up the way they are supposed to. And so we know that there are specific probes, like something like FGFR3 that is equates to the translocation of 14. So a piece of 4 moved with 14, moved over and created this protein FGFR3. And so we can tell whether or not that is overexpressed or not. And so there's this big long list of all these little things that we can use the computer to analyze for that equate to these different translocations. So all of this is basically just helping us to do 2 things. First, figure out best treatment. Second, the fancy word, prognosticate. How long do we think that this treatment will continue to work for you specifically, now that we know a little bit more about your genetics? Because we know that there are some things that respond poorly to certain treatments and some things that we are still working to find better treatments for. And so it can help us to know how frequently we need to monitor you. If we know that this particular genetic change does really well with this treatment, we can be like, okay, we can be comfortable that we're going to monitor this every month, but we'll see this person in person every 6 months. But we know that this person, so in particular chromosome 17 deletion or something, it's linked to the loss of a tumor suppressor gene called TP53. So in our body, we have these, I like to think of it as a policeman. So he's got his helmet on here and, oh, there we go. So we've got a policeman and then we have oncogene. So this is a tumor suppressor. And this is an oncogene. So tumor suppressors are genes that exist within that list of all long proteins that basically is acting like, hey, you don't belong here. I'm pretty sure that you're not supposed to be turned on, you little protein. And so I'm going to shut you down. And so, and then TP53 is a known tumor suppressor protein, and it is linked with a problem with chromosome 17. So when chromosome 17 is messed up, this tumor suppressor gene, this guy that's saying, hey, stop, you're not supposed to be turned on, is now missing. And so it allows that cell to continue to replicate. And then the oncogene, has anybody seen the, now what is it called? I'm blanking now. The little creature was called Gizmo. And if you got water on him, he turned into a gremlin. And so, so he's a normal piece of a little, baby looking fabulous toy until you poured water on him and he turned into this gremlin and he tore your house apart. That's an oncogene. And so, so when you think about breast cancer, things like BRCA1, BRCA2, these are like oncogenes. These get turned on and then they become disastrous. And so oncogenes are also one of these things that we can test for. And so that's why this whole problem, this whole thing about genetics and knowing what things are turned on and turned off helps us to know what your risks are for cancer, how well you respond to cancer treatment, and how often we should be monitoring you. We're going to get now into sort of the chemistry part. So that's all like the cellular part. And now we're going to talk about how do our organs function. So creatinine is a breakdown product of proteins. So our body is constantly regenerating and constantly creating new, and how do you get rid of the old? So the creatinine is a breakdown product of the proteins, and our body is going to filter that out. And so I'm going to just draw you a little picture here of how I think the kidneys function. I want you to think of the kidneys like a coffee filter. And there's these little channels that allow garbage to drop through the coffee filter, and things are going to drop down into our collecting systems and then get into our bladder, where they will then disappear. Okay, so we've got our filter with little channels, and then our collecting systems, which is our renal tubules. So that's the little veins or hoses that are coming off of our kidneys, and then they're going down into our bladder. So our blood passes by here, and things that are the right size are going to drop through the little channels to be filtered out. And then because our body is sometimes less than perfect, potentially something might drop down here. Let's say a little bit of sodium drop down here. Na is the chemical abbreviation for sodium. And our body says, hey, wait a minute, we actually needed some of that. And so there'll be some little guys over here called, that I like to think of as shoppers, that will put some sodium back upstairs. So but the stuff that we really don't need will continue to drop down and into our collecting systems and then get into our bladder where it will be excreted. So with myeloma, these little channels can become blocked up by specifically free light chains. So they start to accumulate here because they're just big enough to block the channels. And so that will mean that our circulating creatinine will go up because it's supposed to be being filtered out. And now my coffee filter is blocked. All of my little channels are filled of these free light chains and no creatinine is escaping as it should be. If the filter becomes damaged, as it can with kidney failure, the channel becomes bigger, and that will allow albumin to escape. And when that happens, where our urine can become quite foamy from the proteins, so when we go to the bathroom, the urine's actually like got little bubbles on it there, and that's because these channels have gotten fat and some albumin has escaped through. So the creatinine is always linked with something called the EGFR. G stands for glomerular, which basically is the fancy name for the filtration rate. So the E is for estimate, and that's because we really don't have a good way of measuring this. There are many different formulas that are used to calculate the estimated GFR. One of them, I don't know, that doesn't matter what they all are, but there are lots of different ways of calculating it. And one of the things that you need to know is that this number does not take your weight into consideration or your age. And these can be important parts of calculating that number, but the computer doesn't know that. It doesn't know your weight. All it knows is what the creatinine is, and then it comes up with this estimated number. And so it just so that you know that if your clinician's particularly worried about it, they'll be doing a better, fancier calculation that includes your age and weight when they're in clinic. So this estimated GFR should be around 60. And if it's low, this means that your kidney is basically not filtering out as much as it should be. And we get a little bit excited when it's under 30. And that means that some medications need to be adjusted. So if you were a diabetic, I would be looking at all of your diabetes medications, in particular metformin, to make sure that we were dosing it accordingly, because these drugs are filtered by the kidney, and now the kidney is not going to do that job well. So as soon as that number is less than 30, it triggers a reassessment of some medications. You can still stay on the medications for the most part. They just might need to be dosed a little bit differently, sometimes less frequently, sometimes reducing the dose. And if that number is less than 10, we get even more excited and potentially are having to call in our kidney specialist to help us figure out what to do. When it comes to myeloma, it's pretty clear what we need to do. We need to get the disease under better control. And so the kidney specialist will just say, you don't need to call me, bud. You need to just do your job better and figure out something. But if the kidney function has gotten to the point where it's causing other troubles, then that person might need dialysis, but that doesn't often happen with myeloma. So when it comes to the stuff that's in the bladder, we shouldn't see a lot of protein there. Remember, the filter is supposed to block albumin from getting out. It's supposed to be too fat. And so we can actually test for albumin in the urine, and you can see it says reference range is like nothing, and it's because there shouldn't be anything there. And then we can actually test something called the albumin creatinine ratio, which should be less than 3. And again, these are both just tests that are telling me what I already know from the first creatinine test, that the kidney function is a little out of whack. There's too much proteins escaping, not enough creatinine, and so it's changing that ratio. And it's just another further method of telling the kidney specialist that we've got some trouble going on here. We can actually do a urine electropheresis test. So again, that fancy graph that's telling me what type of protein is it that's in the urine. Is it all albumin, or is there some other peak here? And so there are some patients who we can only measure the protein for whatever reason. There's not a lot of protein circulating in their blood, but there happens to be a lot of protein in their urine. And so it becomes the one thing that we're measuring all the time. So it becomes like their urine monoclonal protein. The next step is the more about sort of the how is the body functioning. And so these are called electrolytes. And your clinician will often just say your lights, not your whole electrolytes, because we all love our short forms. And so sodium, potassium, chloride, carbon dioxide, and then something called the anion gap. So sodium, or Na, you think of your salt, sodium chloride. Potassium is also part of, both of these are part of the ways that our cells and nerves are innervated. In order for for my hand to know to close, there are a whole pile of little chemical reactions that are happening here, moving an electrical impulse there, and all of these are part of moving those electrical impulses along. And so when I'm looking at all of this, sodium is kind of weird in that it exists on a teeter-totter. If the sodium goes up, it's in, or down, it's always in relation to how well hydrated we are. So if I have too much fluid on board, my sodium will go down, and I've got too much fluid. And as soon as I stop drinking, things will even out. When it comes to potassium, think bananas, orange juice, potato peelings. When it comes to chloride and carbon dioxide, these are actually parts of the way our body regulates. These are positively charged things, and these are negatively charged things. Remember chemistry, biology. So anions and cations. And so These are monitored through our respiratory system and filtration system, and our body is constantly working at keeping these positives and negatives in balance. And that's what this anion gap is. Again, a teeter-totter. I should have a certain number of positives and negatives, and the difference between those positives and negatives should always be around 10. If they are out of whack, if there's too many positives and too many negatives, it will change the gap. And so weirdly, for you guys with multiple myeloma, IgG, if that's where your monoclonal protein is, it's positively charged. And so your gap might be always reported to be weird because you have a little too many positives. And then also, if your albumin is low, it is a negatively charged ion. And so again, it will make your gap out of whack. Do I ever pay attention to the gap? No, I don't. Okay? The only time I'm paying attention to the gap is if it's over 30, it's super high, and it actually means that you're more likely in, if you're diabetic, you're in something called diabetic ketoacidosis, and so you've got too much sugar on board, and it's causing you to produce a bunch of acid, which is driving this gap to be down, so there's too many positives, not enough negatives. And so this whole business is the anion gap is only something that as a clinician I ever pay attention to if it's super, 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 super high. And that's not something that I would expect to see with multiple myeloma. Glucose, basically fancy name for sugar. And again, just mostly paying attention to that if you guys are ever on high-dose steroids. So in some of your initial treatment, you may have received some dexamethasone or prednisone, and those medications drive up our metabolism, which drives up our blood sugar. And so we might want to be paying attention to that glucose in case we're producing too much. There are a lot of us, myself included, who have a little bit of extra on board here. And so if I was to go on steroids, I'd be worried about me getting diabetes because I'm already testing my poor little pancreas that makes all of the insulin in our body. I'm already testing it a lot with what I've already got going on. And so if I add in some steroids to ramp that up a little bit more and produce more sugar, I'm not sure that my body would be able to keep up. So if you're on steroids, we should be regularly checking your glucose levels. Calcium. So with myeloma, there should be, or there can be, incidences where the calcium is super high. In our bones, interestingly, think about it, when we were born, our bones were this tiny. And then somehow they became this big. And so there's a process for growing our bones and rebuilding our bones that exists throughout our lifetime. So there's a constant process of cutting down and building up that is constantly happening. And again, think of it like a teeter-totter. This should be happening at the same rate. Things are being broken down and being built up continuously throughout our lifetime. So the fancy things for this is called an osteoclast, and this is called an osteoblast. C for cutting, B for building. That's how I remember. So an osteoclast and an osteoblast should be working equally. And with myeloma, for some reason, there's a little bit more cutting and not enough building. Is that to do with Bob and the presence of Bob? Is Bob interfering with that process? Probably. So when there's too much cutting, we're releasing calcium into our circulation. And so this can be a measure of disease that is out of control. So some people are diagnosed with their multiple myeloma right at the very beginning because they had a super high calcium level. And when you have a super high calcium level, we have this acronym, bones stones, and abdominal groans. So bones are achy. We can sometimes have kidney stones, and we're super constipated. So somebody shows up to the emergency room and they've got this picture. We're gonna check our electrolyte panel, comes up as super high calcium. I'm gonna have two thoughts in my head. First is something called parathyroid hormone, which is the most common cause of high calcium. But then the second is gonna be multiple myeloma. And so then I'm gonna trigger all of those investigations that we talked about in the very beginning, starting with my with my CBC and my total protein and my immunoglobulins, and then working from there. So a super high calcium level can be corrected with fancy medication. Most people who are on, who have multiple myeloma, we're not asking you to take a calcium supplement. No Tums for you. All right, so we've talked about kidney function, we've talked about electrolytes, now let's talk about our liver function. How are we doing for time? Pretty good. So bilirubin, remember, as I've talked about, that your body has a process for rebuilding and breaking things down. Bilirubin is a breakdown product of our red blood cells. And so this should be being filtered out. If it's not being filtered out, then that number would go up. So I'd ask myself, is there liver trouble? Is there something blocking the liver and not being able for it to do its job? Or is there too many red blood cells being broken down? And so there are fancy tests that I would do for all of that, because basically I'm just looking to see why is that number too high, overproduction or lack of getting rid of it. When it comes to these three tests, I want you to think of the cells within the liver as having sort of an inside and an outside. And the ALT and AST are going to be tests that tell me about, is the inside of the cell, inside of the liver, functioning well? Whereas an alkaline phosphatase lives on the outside of the cell, and when the cell is stressed, alkaline phosphatase gets lifted off. And so it helps me to know the differences in these results. If these two are high, it's something inside the liver, inside the cells of the liver, that's a problem. Whereas if it's an alkaline phosphatase, it's about something that's causing pressure to the liver. So for some reason, things aren't getting out. And so that could be something like a gallstone. Another thing to know is that alkaline phosphatase is also in our bones. And so if I had a fracture of broke my leg, I would see an elevated alkaline phosphatase as well. So sometimes that can be, weirdly, it's not elevated so much when we have this cutting down and broken up high calcium level, doesn't necessarily always be linked with a high alkaline phosphatase level, but it is something that happens when I see a fracture. So that is all of my stuff: liver, kidneys, electrolytes, complete blood count. And we've got good time here. We've got 10 minutes for questions.
Okay.
Hello. Is it possible to find presentation like your presentation maybe, or presentation like this online or something? Because yes, it was really nice presentation, but you know, like it's nice for professional, but for us, like to remember all this stuff, it's pretty difficult. Yeah, to find if it's possible to find something online and check it when you need it.
We have a video of you doing this presentation on Myeloma Canada's YouTube channel. So you can pause and watch it back, rewind, forward. So this presentation she's actually done for us before, and we have it recorded on YouTube. Yes.
Yeah, so it's on your Myeloma Canada website.
Yeah.
I've done this by Zoom for Myeloma Canada, and then I've also done a lecture where I'm drawing out things just like this that talks about what happens when you have a stem cell transplant. So when you're first diagnosed, what is the process of a stem cell transplant, and how do we go about collecting stem cells? Why are we collecting stem cells? And so both of those are on the website.
Yes, we thought the same thing, Victor. We need to get her to put this permanently somewhere.
Okay.
Hi, Nan. I just wanted to add a
So where are we
comment.
coming from? Oh, here. Okay, sorry, yeah.
Look at me.
Yeah, thank you. Okay.
Sorry, I just wanted to add a comment because lucky me, you know, of the crab, I had 3 of them. One of them was ultra high calcium. So in addition to having kidney failure, it also affected my brain function, and I could not complete a sentence. And so I'm not sure if everybody knows that that can be a symptom, but if you know anybody who is having trouble and having their boss complete their sentences for them, very embarrassing, that could also be a sign of myeloma.
Hi, Nan. I have a question about amplification. I don't understand that term, but I've heard it a number of times. Can you
Right.
tell me what that is?
Sure. So remember when we talked about the genetics and we talked about how things can be translocated, and so that now there's a protein. Remember when I talked about how this tiny piece of this is now going to move over here? So now instead of this ending there, there's now something added at the end. These are all little tiny amino acids which form proteins. Our body reads these all together, and this is like a protein recipe. Think of it that way. So now all of a sudden there's these proteins that are beside each other that shouldn't be beside each other, and that's going to form a protein that is now increased in our body that's not supposed to be there.
Thank you.
So it's an amplification of this protein.
Okay. Okay. Thank you very much.
Hello, Nan. One thing that's on my blood work that I don't quite understand is the ratio,
Ratio of,
kappa.
oh, okay. So remember I said there's a teeter-totter, right? And so we know that there should be this amount of lambdas and kappas, and this should be the exact amount that there should be. But what if there's too many lambdas? The ratio of these to that is now out of whack. There's too many of this and too many of that, and we can express that as percentage. So one of the diagnostic criteria for multiple myeloma is if you're 100% out of whack, you have multiple myeloma, and that can be as 100 free light chain or 0.01, that's 1 out of 100. And so that ratio is another thing that we're monitoring. But it's basically just taking how many kappas to how many lambdas. Do you actually pay attention to that? For diagnosis, I certainly do. And remember when we're talking about I put all my pieces of paper now out of whack. When we talked about how we're monitoring for disease, I talked about how we're either going to monitor the M protein, but I'm also going to monitor if your lambdas were, this person's only 49, but I've actually seen that number 4,000. And so I'm going to monitor how well is that 4,000 going down, because my teeter-totter should be coming back into whack. And so that will affect the ratio, right? How many kappas to how many lambdas? That ratio should be coming down.
Hi, I have a chicken or egg question, really.
Sure.
With the translocation, does a translocation create myeloma? Does myeloma create translocations?
Yeah, I don't know. Yeah, it's basically what causes myeloma, and we don't have an answer for that. I just, the sad part is that there are things that happen in our lifetimes. I can tell you that in other cancers, it can be exposure to radiation, it can be exposure to weird chemicals, it can be exposure to viruses. There's a virus that causes lymphoma. And it can be problems with the immune system. People with HIV have higher propensity for certain types of cancer because their immune system is out of whack. And so what is the thing that caused the problem with their immune system? Who knows? But then that did lead to some kind of cancer. So it does make me believe that there's, definitely some things that are out there that cause us to have cancer that are outside of us. And sometimes I think it's about, remember we talked about the police, my tumor suppressor policemen and my oncogene? If my tumor suppressor guy happens to just be looking the other way, that genetic change could happen and it could replicate, become a large number of cells with that problem before he knows it. And then it could be so many that he can't get it back under control. And so now he's got a gremlin going on. And so it's important that those tumor suppressor genes are functioning well all the time. And this is completely not scientific, but my personal philosophy is that we're, you know, if when we're first born, we're, you know, a perfect version of ourselves, but as we're aging, we're a photocopy of a photocopy of a photocopy, because things are constantly being cut down and rebuilt. And that's when, if you ever had an old-fashioned photocopy machine, the image becomes degraded over time.
Just a quick, I'm trying to keep it generic, we don't want to be specific, but you said you don't worry about sodium, et cetera, too low, but I've had to have 2 sodium infusions now, so I wonder what makes the difference at one point?
So
where
it's not that I don't worry about it, it's just that I don't often see low sodium with myeloma. So a low sodium is more about having too much fluid on board, and it has to be dangerously low before a nephrologist specialist will correct a low sodium, because it's very tricky to not give too much sodium. So you have to do it very slowly over a period of time. You can't just bolus in some sodium. It's because the body will become rehydrated in a different way, actually can cause brain damage if you overcorrect a low sodium too quickly. And so you have to be very careful about it. And so if it's super low, my first thing is going to put you on a fluid restriction because you've got too much fluid on board. My second thing is going to be trying to get rid of some fluid, so maybe giving you a water pill. But the third thing would be then consulting a nephrologist. If those 2 things didn't work, we're going to move on to consulting a kidney specialist.
Thank you.
Okay, we just have a question online. I'm going to get the question online, then I'm going to come to that side of the room. Okay, I promise. I'm moving around.
Yeah, so Beverly wants to know if there were a select few tests a person should watch, what would they be?
With myeloma, I'm going to be watching my hemoglobin, my monoclonal protein or serum protein electropheresis, and free light chains, and kidney function. Those 4 things. It will very much depend on whether or not you're on treatment. And because if you're on treatment, there may be other things that your physician is needing to monitor because of the side effects of those treatment. And so I can't speculate about what those could be. So for example, maybe that medication can cause liver damage, and therefore you need to be on, you know, monitoring your liver, et cetera. But if I was a person who was on a treatment holiday, those would be the 4 things I'd watch.
Hi, this is more a comment than a question. I've watched your thing on Myeloma Canada a couple of times, and I'm happy to see you in person and to see how young you are, because I don't want you ever to retire. I'm a big fan of yours.
Done. I'm going to say thank you for thinking I'm young.
Take it and run, girl.
It's gray hair. It's been earned.
So I was noticing that you're studiously ignoring the platelets.
Oh,
So
you know what? I didn't actually. I forgot. So let me go back there. Okay, so platelets, these guys here on your complete blood count. So they're a cell in circulation that basically is what help us to clot. So when you have damage on a vein, if let's say there's a cut here, or on our tissues here, the first thing that will happen is there's some little hormones that are released, and they attract platelets, and the platelets will form a little bundle here, and then they get pulled together to form a scab. Not so much. I want to point out that with platelets, there is a super high range here. So from 150 basically up to 450. So the amount of platelets that we need will be dependent on how much trauma and damage we're doing to ourselves. And so it's a big, huge amount that can go from very little to a whole lot. And so it's not something that varies a whole lot with myeloma. But good pickup.
I was wondering if most people have genetic analysis, or do they have to request it, or are they necessary?
Right. So genetics can only be done on the cells in the marrow. And so this isn't something you're going to say, I really want to have this done. Because if you've had a bone marrow biopsy, I'm going to be the only hematologist that is going to ever talk to you that has had a bone marrow biopsy. And so if you've ever had a bone marrow biopsy, you know it's not pleasant.
It's not that bad. I have one every 4 months. So
Oh, well,
don't.
good for you. I got a lot of cheek to get through, and so it wasn't pleasant. And then you're nervous while you're waiting for results, and that's a stressful time.
If you're going to get one, get it from Dr. Sandhu. He's the best.
Awesome. I'll be sure to tell him. So I work with Dr. Chu, who's coming up, and I work with Dr. Sandhu as well, and have for like 20 years now. So it only can be done on the marrow because that's where cells are replicating, and so that's where you can do those special probes. The question that I ask myself is, will the result change treatment?
Right.
So if it's going to change treatment, then yes, it's something that I would be advocating for. But I would say that for the most part in myeloma right now, I don't think there's one drug that is always only going to be chosen in that genetic situation. I happen to look after patients who have something called chronic lymphocytic leukemia, CLL, and that has some very specific genetic changes that this drug can only be prescribed to those deletion 17p people. And so that changes my treatment. So therefore, I'm going to get that test on them. But for you and myeloma, I don't think, and Dr. Sandhu or Dr. Chu can correct me if I'm wrong, that there's any specific treatment that is only allowed if this. There may be clinical trials. Dr. Chu's back there. I think he's nodding. There may be clinical trials that are dictating that. And so that's why there's often a bone marrow biopsy required for a clinical trial.
Thank you.
Okay, did I get everybody? All right.
Awesome.
Online, Sophia, how is everyone there? Okay.
Are you guys sure? And we're going to let her go? Are you going to stay for? No, for the day, not for permanent, for the day.
That's right. And remember, it's available online.
Yes.
As well as the stem cell collection lecture. And I really want to thank you actually for letting me come do this today. I really love this kind of lecture where it's me just doodling and getting to share what I already know without having to pull together some fancy PowerPoint presentation. Dr. Chu will have one of those.
Yeah. Awesome. No, thank you, Nan. Thank you very much.